Uh, Dr. Subhash, can you hear me?
Yes, sir, I can hear you.
I'm grateful, Dr. Subhash.
Good evening, Alok.
Good evening, Dr. Sujit. How are you?
Yeah, I'm fine. I'm fine. How are you?
I'm good, thank you. Thank you for joining us.
Yeah.
Are you happy to go first with
Yes, I'm more than happy.
Fantastic. Please feel free to share at any point. I've
Okay.
enabled you as co-host.
Yeah.
That's so kind of you. That's beautiful. Amazing. We'll let Nadya join us. I think she'll join us exactly in a few minutes.
Absolutely fine. No problem, Alok. I'll wait to hear from you before I start.
No problems. Thank you.
I've got a few cases, Alok. I'll sort of be guided by you. Let me know when to stop and I can stop because I don't know how many are presenting.
So we've got 4 today. So
Okay.
my feeling at the moment is let's just crack on.
Okay.
And Kirti has very kindly agreed that if we run out of time, then she will very kindly sacrifice, which I'm grateful for. So please don't worry. Please carry on. We'd love to see all 4 cases.
Okay. So shall I start?
No, I would like Nadya to join us because
she's
she's one of the co-instructors today, and I think having a critique from her is it's kind of an honor. So
no, absolutely.
So folks, I am going to just give an introduction as we're starting in about 2 minutes. First of all, I'd like to welcome all of you. And clearly we've had quite a clamor to share and kind of have peer review. So for the first 30 minutes of our session, we'll be having a peer review for colleagues with Dr. Sujit Pereira from the Homerton University Hospital starting. Sujit will introduce himself. But just again, house rules. So I would humbly request that you all mute yourself while the presenters are speaking. Today is a very special day for us because we have with us, I would say, normally we talk about father and mothers in medicine. When we talk about people who've contributed in a huge way. And I would say that point of care ultrasound is graced by some very renowned individuals, people I think who make a very big difference to formative training and the development of individuals. And one of those individuals I've had the honor of training under and training with, and that is Dr. Nadya Yousef, who is a consultant neonatologist in Paris University Hospitals. Nadya has a very special interest in a variety of fields, which include point-of-care ultrasound, especially lung ultrasound, heart-lung interaction. But in addition to that, she's extremely talented. She's also got a special interest in simulation. She's done a huge amount of research and has a huge amount of publication in lung ultrasound and in neonatal simulation. She speaks a multitude of languages, and I think I'm in absolute awe of the amount of teaching and education that she does worldwide in trying to forward a lot of her special interests. I think we couldn't be more grateful to have her here, in the role of a guest speaker for us, who is going to be speaking to us over the next few sessions, guiding us on this very special area. And I would like to welcome her, and I would like to invite all of you to welcome her as well. Nadya, we'd be very grateful if you could just say a few words. We're honored to have you here with us.
Thank you so very much, Alok, for this incredibly touching introduction, and thank you above all for inviting me to be part of this project. What Alok has said, I must really give back in return. I am honored to be working with Alok, who also has taught me a lot. I've just come back from a 3-day course in Southampton. His course on neonatal simulation and also difficult airways, and I have suddenly learned so much. So it is an honor for me and a privilege to be able to participate in such a project. I'm also very excited to get to know you all. As Alok said, point of care ultrasound and particularly lung ultrasound is one of my very special interest areas. It has transformed the way I'm managing my patients and my teams also. I feel that it fills in a gap, something that was missing, I guess, at the bedside. It has become an extension for me, and I believe for many of us. Alok, please correct me if you feel that I'm wrong. It has become the extension of the physical examination. It's giving us a view, a visual view, really, of what before we were only able to see, or externally or with the stethoscope and so forth. So I feel lost without my ultrasound probe. I feel that it adds an additional dimension. I'm also very happy to see so many of you here today. I know that by now you have had many sessions and many of you have already started to perform ultrasound. So I'm very excited for this, for me, first peer review. And I'm really looking forward to this session. So thank you all, and a big thank you to Alok. I'm forever grateful to you.
We're grateful to have you here, and we've got a few colleagues who are going to share. So because it's 4 o'clock, I'm just going to start recording. So Dr. Sujit, I hand over to you. I'm going to mute myself, and the kind of pattern that we follow with peer review is we let our colleagues present the case, normally go through the lung ultrasound, have a discussion, and then basically get our expert peer review person to comment, and in particular critique the lung ultrasound. We have a few. I think Sujit is going to present about 4 cases today, and followed by Sujit, we will have, just in that order, just so that the next person can be ready. We have got Anna. So Anna would be the next person, followed by Kirti. So Sujit, I hand over to you. Could you please mute yourselves, please?
Thank you so much, Alok. I'm Dr. Pereira. I'm one of the neonatal consultants based at the London hospital. Thank you so much, Dr. Yousef. I feel privileged. You've been an inspiration to me, and I sort of missed both of your face-to-face launch courses because of the pandemic, but I hope someday to come and sort of do some scans with you. So I'm going to start off with the first case. So this is a term baby. This was an ex-utero transfer to a hospital with a diagnosis of HIE and PPH and undergoing therapeutic hypothermia. There was some meconium exposure, initially requiring 100% oxygen, and then that was weaned quickly to 30%, minimal respiratory support on dual inotropes, had a rising CRP, and this scan was done when the baby was on sort of minimal invasive respiratory support in about 30% oxygen. So so this is the right side. I sort of didn't store the right anterior upper images, but in the right anterior lower images, you can see, so 3 rib spaces, 3 ribs, 2 rib spaces. You can see a clear thin pleural line, which is clearly moving. So there is pleural sliding, and you can see the odd sort of small comet tail. I'm seeing clearly A lines through and through on the anterior side. On the lateral side, there is, I can see a hint of A line there. It's not the best picture because when I did the first few scans, I realized it's quite dark. The gain is on the lower side. And I sort of, this picture is slightly sort of a sub-xiphoid view, sort of going towards the right-hand side. And this is the left side where I sort of increase the gain. And again, you can see clear, nice thin pleural line. Pleural sliding is present. I'm seeing A lines throughout, few comet tails. I'm not seeing any obvious B lines. And on the anterior lower side, again, nice, beautiful A lines. Sort of the bamboo sign I'm seeing, and good pleural lines, good pleural sliding. Laterally, that's the same. I'm seeing the odd sort of B line there, but I would say this is sort of more of an A profile. And on the lateral scanning, I mean, this is in the left lower zone. I don't know, I'm not sure what I'm seeing. I can see a little bit of consolidation. I don't know if it is consolidation or not, but this is what the X-ray looked like for this baby. And I don't know, the cardiac silhouette was sort of slightly fuzzy in the left lower margin. And this baby was managed with a single antimicrobial agent. CRP was downtrending and was extubated to non-invasive respiratory support. So that is the first case.
Do we discuss that now? Or
yes, Nadya, go for it. Yep.
Well, thank you very much. The scans you were showing, this one, for example, is that on day 1, or is this afterwards when you said the baby had gone on to increase CRP levels?
So Nadya, this was done when the baby was in about 30% oxygen, minimal respiratory support.
Okay. Well, thank you for presenting this case. I have just a few comments about your settings. I totally agree with what you said. I think you've presented this really nicely. The scans are very nicely done. However, I have a question regarding your settings, especially if you could show the second one where you have all the way down. Yeah, here. I'm just wondering, but that's also a question of preference. I feel that your filters are a bit too high. We can clearly see lung sliding, exactly as you described, very nice A profile everywhere, and a couple of B lines here and there, especially laterally. But I'm just wondering, I would suggest that you play around with your settings, because I think I think you can get even better images. This is not you not doing the scans correctly. They're very beautiful. It's just a question of machine settings. And I'm unsure which machine you're using, but I think, like, for example, the lateral scan, we're having problems seeing the individual B lines, but we should be able to see them. So I think that is something in the settings. I mean, I don't know, harmonics or whatever is making you have more difficult to see that. And going back to the really lower end, the one that's on your screen is on the right-hand side, you're on the abdomen. So I think you either have, I don't know, this is the left side, looks maybe like a, I don't know, the stomach or something. This is not the lung in any case. Okay. You've got a spleen up there, and I think a bit of the stomach or something. So what you should do is always, which you have probably done above here, I don't know, no, I'm pointing at your screen so you can't see my arrow, sorry about that. I think you might have the diaphragm there. So what I'm missing for your lateral view, which would make it easier, I think, for you to make an assessment about whether that is a consolidation or whether that is, you know, something else, is that we don't see the diaphragm. I would expect to see the diaphragm in between. Okay. So for me, this is a very nicely looking lung. You did talk about this baby having a history of meconium stained fluid, but we cannot see any signs on this kind of aspirations. It might be maybe like a microconsolidation, this lateral scan in the middle intercostal space, but it's difficult to say if it has any clinical significance, really. I don't know what you others, if you would agree with my assessment and with Suji's assessment, but for me, this fourth one, the one it's after, so you have anterior, upper, anterior, lower, and lateral. This for me is the abdomen. Okay. So always be sure where you are, and that is really tricky sometimes. But I think it's really important to use always scan all the way down to the diaphragm, be able to use that as your limit, because you do find something. The question is it pathology. The second thing it might be, though, is that you might have a mirrored image that you're actually seeing intra-abdominal, or think you're seeing intra-abdominal organs in your thoracic cavity. But if you just move your probe, that changes. You're using a linear, microlinear probe. So I don't think we would see that much, but yeah, this lung looks really nice to me. Oh, very nice scans, well done.
No, thank you so much for the feedback, Dr. Yousef. I was using a hockey stick, and I think this was sort of set at 10 hertz. And I think the last fourth picture, it was a little bit of a struggle. So it was probably my first one that I was sort of struggled a little bit. So I suspect it probably will be spleen or something that I was seeing.
The images look nice. Doesn't look like you were struggling at all. But I think you, I would really suggest that you play around with your presets and see if you could get something else, because I think it would be useful. I think you can even get to see the sliding even better than what you do. I mean, we can see it, but I suspect you could make life a bit more easier for yourself if you could look into the setting.
Okay. So I'll move on. I wanted to go through, maybe I have a few more scans, but I think the last sort of 4 cases are a little bit more interesting. So I'll start with this. So this is a term baby born by elective C-section, not in labor, requiring a little bit of oxygen in labor ward. So therefore was admitted. Respiratory support following admission was 8 liters of nasal prong oxygen. And we started some feeds. I used a different probe for this. So I used the linear 11 hertz probe. The baby was prone, and therefore I sort of scanned R5, R6 first. So I'm seeing sort of nice thin pleural line. There is sliding. I can see a few A lines. I can't see any obvious B lines. Same for R6, lots of A lines, thin pleura. And I can appreciate sliding, and this is the lateral image. Again, the same. I can see just probably a hint of A lines there, and I suspect again the gain was a bit suboptimal. I turned the baby over, and this was done 30 minutes later. So R1 and R2. Again, nice thin pleural line. You can see some comet tails, and I can see an A line there. There is couple of B lines coming all the way down to the bottom, and it's more so in R2, where you can see nice thick lines, comet tails, A line, and I can see sort of B line, so that's the double lung point, seeing sort of lung transition. And when I move to the left side, again, I did the posterior, so that's L5, L6, nice, good, a lot of A lines seen with good pleural sliding. Oops, and on the lateral side, again, I'm seeing sort of a few comet tails, good pleural sliding A lines, and this is again 30 minutes after I turn the baby supine. So I'm sort of seeing more B lines, but I can still see a hint of A line. Again, the gain is something that I probably need to play around a little bit with. Clinically, so this was the X-ray. It was a rotated, slightly rotated film, expiratory film, but this baby was breathing unaided after 6 hours of nasal canal oxygen, clinically well, stopped all the antibiotics. Oh, sorry, I'm going the wrong way. Yeah.
So what was your diagnosis?
So
ultrasound diagnosis, at least.
Well, I suspect it's probably in keeping with transient tachypnea, given the history that this was a category 3 cold section where the mom was not in labor, with negative inflammatory markers and a brief period of brief oxygen requirement.
So, and how was the scan? How did you find that?
So, so doing the scan, so this is, my experience with doing posterior scans is quite limited because majority of the scans that I've done previously were sort of when the baby was supine. So what I found a bit tricky in the posterior R5, R6 was all this tissue that you get is probably the erector spinae muscles and all of this going through. So I found everything was a bit more deeper down. But I mean, you can see quite a lot of rib spaces, and I didn't change, apart from the depth coming down to 4 centimeters, I didn't change anything on that linear 11 Hertz probe. But the images that I got, I mean, I can clearly see good A lines with pleural sliding, which was more exaggerated when the baby started to cry. But yeah, I mean, this is a big baby, a 3.8 kilo baby, so that especially in the lateral side, the footprint is quite big, and just put it laterally, you capture the whole sort of left lateral slide. So to me, the findings are sort of more in keeping with the possible transient tachypnea.
I think you did. It's a beautiful summary here, and it is challenging to. I mean, the view is a bit different because the angle of the ribs is also a bit different on the back, right? Totally agree with you that especially in older babies, and especially if they're vigorous like this one, moving, you have some space to go down. But the advantage I feel is like you've shown that you have many intercostal spaces, which is nice, and if you're really lucky, especially in smaller babies, you can actually get both lungs in the same scan, which just looks really cool. Looks like a butterfly, like a real bat. But going back to this one, I totally agree with you. The lung is really well aerated. We have a few areas of B lines, so it could totally be in line with neonatal transitioning, a bit delayed, and that really corresponds with the clinical picture. When it comes to the quality of the images, I also agree with you. I think you've made a very nice assessment. I still have an issue though with the lung sliding, especially in image 5 and especially 6. I find it especially tricky to see whether there is lung sliding or not. I think that has nothing to do, again, with the quality of the image, because actually, if we look at number 6, it's really nice, right? We have 1, 2, 3, 4, almost 5 intercostal spaces. The pleural line we can see, in spite of, I know it's really technically difficult to scan vigorous babies, 3-point-something kilograms, so well done for that. But I really, really have difficulty seeing lung sliding. I have indirect signs, like in the let's say it's almost the second intercostal space from the left of the screen in 6, where I have signs that it's like, yeah, exactly. You can see it sliding. But other than that, I really have problems. And I think that is, again, the settings. And I know that Alok will walk you through tips on how we can actually, what I call filters are, it's post-image processing. The machines are now so sophisticated and they remove the noise, but we're looking at noise. And I feel really what I've learned with time is the trickiest artifact to see, artifact or real image, I don't know, is lung sliding. It can be really, really tricky to see if you have settings that kind of wipe away that. So in the anterior regions, you can see that really nicely. And you also have the B line, so that's kind of a giveaway. But in the posterior regions, I feel like in images or videos, clips 5 and 6, it's much more tricky. So really well done. I totally agree with your assessments. I think you've done a very good and complete job. I think, again, that when you have time, play around and see if you something that makes it easier. Because I'm sure there is lung sliding, but life is so much easier when you can see it. And if you have a doubt, like in 6, in a baby that's not doing well, that could be a source of concern. So I agree with you. So very nice.
No, I agree with the fact that in the 6 R5 and R6 the baby was asleep, and I initially thought also there wasn't much lung sliding, but at some point he screamed and I could appreciate it a bit more. But I see a point, and that's very useful.
That is often I'm sorry, Sajid. I'm sorry to interrupt you. I didn't mean to do that. I'll just add that many of my colleagues who start to use lung ultrasound come back saying, we can't see lung sliding. And I'm talking also with Daniel Lichtenstein, that I think it really is the machine settings more than the depth and the gain and all this. This is really a question of specific settings, harmonics, or I don't know what. So this is something I'm sure we'll go through. And every machine is a bit different. So feel free to, if you're lucky enough to have a technician help you, please do. If not, just play around with the presets.
So the next case is a 32-week DCDA twin who was initially on non-invasive respiratory support, admitted in 30% oxygen, which quickly weaned down to sort of air. And then the baby was noted to have a slightly increased oxygen requirement at 36 hours, noted to have increased respiratory support. And so this scan was done with a 10 Hertz hockey stick probe. So this is on the right side, R1 and R2, and this is lateral. So you can see the pleural line, I mean, it does look a bit more thicker anteriorly, but I can sort of appreciate pleural sliding. I can just about see a hint of A line there. Same for the right lower side. There is pleural sliding, thin pleura. There is a little bit of infection there, some, I don't know, subpleural consolidation, probably a bit of A-line there. Again, there are issues with gain here. And this is laterally, where you're seeing sort of more compact B-lines in this baby. And on the left side, so that is anterior, that is left lower, and this is left lateral. So here, I mean, you can see the pleura doesn't move very much. And I can just probably see a hint of movement there. Here also, I'm not sure, I can sort of more appreciate pleural sort of movement there. But this baby essentially had a pneumothorax, which was needled overnight. And when I came the following morning, I did this ultrasound, and you can see, I mean, there is no pleural sliding there, and you're seeing the stratosphere sign. So this baby, and clinically, this is the X-ray, this was done after that scan. Clinically, there is the left hemithorax was elevated, cold light positive, absent breath sound. So this baby had a chest drain put in, and quickly the respiratory support, sort of everything got better. And the drain wasn't bubbling. We clamped it. 6 hours later, it reaccumulated. and then was unclamped. And this was the scan that is almost done 12 hours after that unclamping. So this is the right side. So you're seeing thin pleural. I can appreciate pleural sliding on the right side. A lines. This is right R2. Again, I'm seeing A lines. I can appreciate some pleural sliding. And on lateral imaging, slightly thickened pleura, A lines plus I'm seeing B lines. And this is the left side. So R1, R2, and this is lateral. So R1, L1, this is 12 hours after the drain was unclamped. I can see pleural sliding. And I mean, I can see a few comet tails. Here, this is left lower, you're seeing pleural sliding here. I'm unable to see any pleural sliding here. And I can see some pleural sliding there and the same line. I think that's probably the lung point. And laterally, I'm seeing the pleura moving. So clinically, I didn't repeat an X-ray, which saved me another point. So the baby was the scan was done yesterday. So the chest drain is still in C2, is on minimal respiratory support. That's where we are.
Thank you very much, Sujit. Could we go back to the first, this very interesting case?
On the right side?
Well, the first, yes, starting from here. So this is the right side. Going back to the images, again, you have very nicely described what we're seeing, but it's difficult for me because I was not doing the scan with you. The settings are difficult. It's really dark when it comes to the gain. But here we can appreciate lung sliding. We have no doubt about it. Plus we have multiple B lines. Same is true in anterior lower and in the lateral. But it's not easy to say if this is really an moderately aerated lung or not. I mean, we can see the multiple B lines, but it's too dark to be able to really know more about the lung and the anterior upper and lower, in my opinion. So I'm not really able to evaluate. The lateral looks white everywhere. We've got these tiny, tiny microconsolidations. So this is like a lung white appearance, even though again, it's difficult. Could we move on to the next? So that means the left. And this is where I found it really difficult because of the settings. Like I said, in my opinion, assessing lung sliding when the settings are like this is extremely difficult. In the first from the left intercostal space, I agree. There doesn't seem to be lung sliding, but in the second, I'm really unsure. And in the lower, again, we cannot really see in the lateral, there is lung sliding. So my question is, when you did then do the M mode and when you did then make the diagnosis of absent lung sliding, where did you find the lung point?
So initially it was lower down. It was in L2. I sort of, there was another picture where I know I could see the lower half moving.
Because it's more a question of medial or lateral. When you want to assess the volume very, very roughly, of course, of a pneumothorax, the idea is the further, let's say, lateral your lung point is, the larger your pneumothorax. So I'm very surprised with well, I'm just very curious about where was the lung point, because I'm a bit surprised by the course.
So what you're suggesting is if it's more lateral, you're likely to have a bigger pneumothorax.
Yes, I'm very surprised that this baby was needling, for example. If the lung point had been in the anterior chest areas, upper or lower, whatever, it usually is both upper and lower. But let's say if it had been somewhere around, I don't know, medial clavicular or left clavicular. It might just have been like a tiny bubble, maybe even mediastinum. But we don't have that information. But what I can see is laterally, there is lung sliding because the lung is white. So that leads me, but I don't know where this lateral scan is, maybe medial clavicular, medial axillary line, possibly. I'm not sure. Then that pneumothorax is not that large.
Yeah, no, there was another X-ray which I didn't put at, which was done. So the needling was done overnight. And so when I came the next day, the morning rounds, they were intubating this baby. By then, it was
probably it had enlarged.
Yeah, and then after the ventilation, it had gotten bigger.
Okay, could we move on to the next one? So here the question would be, where is the lung point? Without the lung point, it's very difficult to make an assessment of the pneumothorax. Could we, sorry, with your M mode?
Yeah. Let's.
Here. So this is taken in, I guess, the intercostal space, because right beside it, you know, you've got two intercostal spaces. So the one that's on the left of the screen, we agree there's no lung sliding, but the one that's on the right of the screen, there seems to be lung sliding. So this should be your lung point. So I don't know exactly where this is.
So are you referring to here, Dr. Yousef?
Yes, this seems to be sliding here. So I'm guessing that this might be the lung point. I'm quite unsure. My question is to you, whether that is correct. And maybe you did put, I don't know where you put your cursor for your.
So the cursor I put it was sort
here. Okay. And did you put the cursor in the adjacent one here?
No, I didn't.
Was the lung sliding? No, that would have been very useful because that would really confirm where your lung point is. And that would give you an idea. That was before the baby deteriorated, of course. That would have given you also a confirmation of your size. I would definitely do that. If you have time, of course, if your baby's crashing. I would definitely, once you have confirmed the absence of lung sliding, once you have found, you have to really determine where your lung point is. Be sure that it really is your lung point. And if you're unsure because of settings or because you could be unsure, it's not always easy to see. I would also place the M mode there. I believe from the scan I see, although of course I might be wrong, that your lung point is somewhere over here, and depending on where that is. And when we go back then to once the drain was inserted and you come back. Sorry.
Let me go there. So this is the right side. So this is the left side.
So there's lung sliding everywhere. So there's no residual pneumothorax. So that would mean.
What about here in this part, Dr. Yousef?
Yeah, but the thing is, when you put your probe, if you can see where you have your marker, you've got lung sliding on the right, on the left of that. So you might have a micro bubble of air, but that doesn't mean anything. So this is why I think it's always very important to have, when you're doing the scan, to have a dynamic view. Because often we might be faced with having like micro bubbles of air that persist. But since what I believe I can see, but please correct me if I'm wrong, is that in the, sorry, we just got the mic. Side of this non-sliding, you've got some sliding, don't you?
Yeah.
That this is not significant. Nor can this be causing your patient any distress.
So, Dr. Yousef, what I'm taking is, if you're doing a scan, the more lateral you have absence of lung sliding, the more bigger your pneumothorax is likely to be. Is my understanding correct?
Could you please repeat that? Sorry.
So when you do the scan, my understanding is more laterally you have your lung point, the more bigger your pneumothorax is likely to be. Okay. Yeah, I'm a bit surprised that even sort of micro bubbles you can pick it up that way, and it's interesting.
That is really it goes to show you the power of lung ultrasound, but it also goes to show you that you will pick up hundreds of tiny pneumothoraces that have absolutely no clinical significance, which is why it is very important to determine where your lung point is. When we started to use lung ultrasound, we were quite stressed because we found so many children diagnosed with pneumothorax. And now we've just found out that this is the age in life where you find them. If your baby is behaving correctly, if your pneumothorax is limited to your anterior chest wall, we definitely do not do anything for this patient. If the patient starts to deteriorate, we will rescan to assess whether or not that has increased in size as per the lung point. If it remains really in the anterior chest wall, we will really not do anything. Many babies are really well. It's that we see that, well, like this tiny microbubble, you see that all the time. If the lung point starts to cross your middle axillary line, you might consider doing something about it if your patient is not okay. So many pneumothoraces you will be picking up, you will absolutely not be able to see on the chest X-ray. So it will show you maybe too much. And going back to the baby that was needled and then drained, of course, it would have been very interesting to have a lung ultrasound scan at that point. But the first scan you had leads me, but then again, we have some issues regarding lung sliding and the fact that we're a bit unsure how large that was at the time. That would have been very useful. But of course, the clinical picture always goes first. But I think with experience, you will find that it's really useful. Personally, I no longer use chest X-rays for pneumothoraces. They do not add any helpful information for me in my setting. But my juniors, many of them still prefer to do so. So thank you very much for this interesting presentation.
No, thank you. Alok, I have cases, but if there are others, shall I unshare?
Is that okay? We'll let Anna present next. And my gut feeling is because we want to maximize Nadya's presentation time. What you can do is we have another session tomorrow. So by all means, tomorrow Zaruddin will be starting first, but please feel free to go next. So if I could ask you to unshare.
Yeah, I've unshared.
That's so kind. So, Anna, I've made you co-host, so you can start sharing when you're happy.
I'm not sharing.
Sujit, have you stopped sharing?
I have stopped sharing. I can see Anna's screen.
Lovely. Anna, we can see your screen. Amazing. Thank you.
Okay. Hi, Nadia. Thank you for being here. It's a pleasure to listen to you again. I'll present a clinical case. It's a 33-week girl that was born with a good weight, 2160. It was the mother was in the hospital because she was bleeding from a placenta previa. She completed the antenatal corticosteroids, and 2 or 3 days after she's in the hospital, she started bleeding again, and so she had an emergency C-section. The baby born well and was connected to CPAP, but it gets worse, and we had to increase the pressures and the FiO2 to 30–35%. He was with a higher PCO2 and a mild respiratory distress. The CRP was negative. And this was the admission X-ray. I wasn't there in that day. The people thought it was a TTN because maybe there was a caesulitis in here. But in the next day, the baby was worse, and I did a lung ultrasound. And I think we can see that there is a white lung. I think we can see sliding really well with B-lines, compact B-lines, and that the pleural line is a bit coarse, irregular. And this is all in all 3 right scans. we see the same appearance, and also in the left side. So I think here we can see also some subpleural consolidations. I don't know if you agree with me. And a B profile, compact B lines. So I thought this was more an RDS than TTN, and the BRAT score was 12 in 18, and the baby was getting worse with more oxygen needs, so we did the surfactant without doing an X-ray, and I was glad about that. I don't know if you want to comment the scans. I have, after the surfactant, 9 hours after I did new scans, so maybe
how were they? Do you want us to check the first scans first, or do you want us to wait till we see your control scans?
For me, it's okay, like you want. I can finish.
Okay, go ahead, please.
Okay. So 9 hours after surfactant, I repeated the ultrasound, and in some places of the lung, there was a better appearance with A lines, like here in R2. I think we can see sliding, but in DALF, I made the M mode, and we had a C-short sign. This is a bit blurred because it's a picture of a picture, because I couldn't find the original. Can we talk about a double lung point here? Or I'm not sure if you can call it like that. And on the left side, it was a bit better too, with some A lines here in the L2, but laterally worse with the compact B lines. Good sliding everywhere, and the coarse pleural line. And this is it. These are my settings. I asked the technician of GA to come to help me and adjust these settings like in this article. And I use 12L prong. And I think I'm okay with my images.
Yeah, thank you, Anna. And this was really well done. I also like the fact that you have showed us all the settings. That is so professional. Wow. Would you like us to go back to your first scan?
Yes.
So this was a 33-week-old preterm baby who had respiratory distress, and that you then diagnosed both clinically and ultrasonography with probable RDS, and she improved after surfactants. So I agree with you that we have a nice overview of the lung. The lung does not look well aerated. There's totally agree with you. There is lung sliding everywhere, and we can see that pretty well. I think the gain is what works best for you. If this is something, I'm someone who really likes a lot of contrast and darker pictures, but that doesn't mean that you can't use this. What's important is that it works for you, and we all can see exactly what you described. Multiple B lines, a thickened, and possibly somewhere a bit irregular pearl line, and no sparing, meaning that we have no areas except one, it seems. If we can move over to the other side, the left side, it seems that we have in L1 and L2, we have some sparing, meaning that we have some A lines. And sometimes we have that, I think. Is this a case of a preterm baby with a mixed picture of RDS and TTN, or is it classic RDS? I don't know, but at least she did behave like classic RDS, so that makes sense. When we move to the pictures you took after surfactants, they seem to be quite some, the scoring system Is this a 1? Is it a 2 on L2? I don't know. In any case, you have no consolidation that should be counted as a 3. So maybe we have a score of somewhere 11 or 12, but that gives the same result. So I totally agree with you. The images are nicely placed. We can follow the pleural line. We understand that there is the L1, L2 with the heart. That's always a bit tricky. So well done for managing to show us that. It's not easy at all. Then after surfactants, are you surprised by the way the lung looks?
I was not surprised because I read and listen you saying that sometimes we cannot see the improvements in lung ultrasound so fast.
No, it's very interesting. Sometimes, I mean, people are starting to look at clearance and how different ventilation strategies could show that. But this baby was on BPAP, so there should have been some nice mean airway pressure. But you can see, I agree with you that the lung is starting to clear up. And the question was, is this a double lung point? It does look like a double lung point. In any case, we have 2 patterns in the same image, which is the definition of a double lung point. Both are sliding and one is white and the other one is. So again, this baby responded really well to surfactant. So I agree with you that this is the diagnosis we would have made. But we know there is a subgroup of babies that is somewhere in between that usually have one area spared. But I think I totally agree with you. I would stay with the diagnosis of severe RDS. I don't know if we should call this a double lung point or not, but technically it is a double lung point. I agree with you. Very nicely done for the seashore sign checking, because it could have been that there was a small bubble, although we can see there is with the B lines there on the sliding. And I agree with you also, we have areas of microconsolidation and R3 that remain, but we have no effusion. So this is a very nice case. Thank you for sharing that with us.
Thank you. I only have this case.
That's really kind, Anna. That means, Kirti, can you hear me?
Can I do one case or?
Yeah, that would be fantastic, Kirti. So we'll get one case in from you. And then I have just posted on the WhatsApp group about the schedule for tomorrow with the 4 presenters. So go for it, Kirti. Share your screen, please. Kirti, do introduce yourself to Nadya.
1 second.
We can see your screen.
Oh, is it? Hi, I'm one of the clinical fellows. I'm working at University College London Hospital.
Hi, Kirti.
Hi.
Please go ahead and present. I'm looking forward to seeing your case.
Okay, so this is a term baby, 41 weeks, with a birth weight of about 4 kilos, had respiratory distress at 3 hours of life, and was on a high flow of 6 liters with oxygen of 25%. These were some of the images. So in the first one, we can see the pleural line is thickened. There is lung sliding present, and there are some B lines, but I think they're less than 3, and I scored 1. And on the left anterior side again, I wonder if this pleural line is normal, or would you call it thickened? Again, the lung sliding is present. We can see all the A lines, so I scored it just 0. In the right lateral area, this is a thickened pleural line with lung sliding present, subpleural consolidations, and B lines. So I scored it as 2. In the left lateral, again, there's thickened lung pleural line, present lung sliding. Again, I think these are all the subpleural consolidations, and I scored it as 2. Because I have this linear probe and not a hockey stick, so it covers R1 and R2 together. So I don't know if the scoring would still be valid, but I scored it the same as right anterior, so 1, 1, 2, 0, 0, and 2, then it came to 6.
Thank you very much, Kirti. Oh, sorry. Sorry about that. Please go ahead.
And this was the chest X-ray that we had. We didn't have to give the baby surfactant because the FO2 requirement remained very low.
Thank you. This is a very interesting case. Could we go back to your first slide with the first images?
Mm-hmm.
How did you feel it was getting the images? The term baby can be very vigorous.
It was really hard, yeah, because the baby was very vigorous and moving continuously.
Yes. So well done for getting these images. I think, however, because you did ask whether you thought the pleural line was thickened or not. But I think that is very difficult to tell from the clips you're showing us. I know you must have made a very thorough examination. It could look thickened, but that would also depend on how you orient in your probe. I think that globally, this lung looks really well aerated. I'm not really sure how many B lines there are, because I think it's a little bit about the angle of how you're holding the probe. I have no problem using the linear probe and not a hockey stick one. It all depends on what you have, but you have to learn exactly like you're doing now, how to interpret the images you get with your probe. So here we see 3 or 4 intercostal spaces. The pleural line might be a little bit thickened, especially where you have what might be the B lines, but that I think would be interesting to see when you're doing a sweep. Did you manage to do that and get an overview?
You mean the horizontal sweep?
No, not necessarily. I mean, when you scan, again, I know this was a vigorous baby, but to get an overview of whether this is just how you're holding your probe or whether the line is thickened or not, it's always good to have a slight movement of your wrist to check, because depending on how you're holding your probe, the line might look a bit thickened, as it does here. So I can't answer your question. I don't know whether this line was thickened or if it's the question of how you're holding your probe. What I can say is you have one B line for sure, maybe a second, not sure about the third one. So in any case, what you're saying is you have less than 3 B lines per intercostal space, so that would be a score of a 0.
Okay.
And when we look at the left anterior, left is always tricky with the heart, and I can see that was an issue, especially with the baby that's moving, because your question was, is this pleural line regular? Again, I think it's really difficult to tell from the scan. It doesn't look regular, but it could just be a question of how the image is taken.
Okay.
Could we move to, the next one, please? And here, also, it's difficult with the settings because it's really very grainy. So I don't know. We have the impression in the intercostal space that's to the right of the screen that it is irregular and that we have 1, 2, I don't know how many B lines there. Less than the one when you go upwards, so the middle one, and less going up. But I think where it would be very interesting is to see how you could check your settings. This is a linear probe. I'm not sure which settings you were using, if they were presets or not, but I think it would be easier if you were able to like work a little bit on your presets, because I'm sure for you this could not be very easy to identify. Remember B lines, for example, I can see you said 3 per intercostal space. I'm not really sure there are 3 per intercostal space.
Okay, I thought that
because it's really difficult for me. Maybe this is just the images when you record them. Maybe it's easier to see on the ultrasound machine. But I have a problem identifying the B lines because the lower part of the screen is so fuzzy. So I don't know how many there are, but if we were supposed to always count them from the pleural line, we can say on the lowest intercostal space, we have at least 2, possibly 3, but we can't follow them all the way down. But I think they could be, it's just we have problems seeing them with this resolution. In the middle one, there's maybe 2. So going back to the score, if we did have 3, that would be a score of 1. And then to the left lateral one. It's also, we can see that this baby is giving you a very hard time.
Yeah, it's really hard to do this.
Yeah, I can understand. They are really, really complicated to scan. So it's really great that you managed to show us all these scans. What I'm guessing is that we have these A lines. It's difficult to say how many B lines we have, but in the sweeping action, we might have two B lines, two intercostal spaces where we have more than 3 B lines, but we can also see, and the baby lets you show us some A lines. So I would also score that a 1 maximum because we do have A lines. But I think my comment would be that it's much easier to interpret the scans when you know your machine better, because I think that this is making you hard to interpret. It's difficult to individualize the B lines and really assess the pleural line. So I would also try with babies that are not so difficult to scan, like the 4-kilogram baby. And I hope that maybe we could reassess your scan at the end of my talk, when I'll be talking a bit more about the scores. I hope it makes it a bit clearer on the scoring system, whichever one you choose.
Okay.
So what was your clinical conclusion for that baby?
So clinically, we thought it was mild RDS bar TTN, and we didn't have to do anything. He just got the tachypnea resolved within over the next few hours, and he had got 21%.
What I can see from your scans is, for me, a well-aerated lung with some interstitial fluid. So that totally makes sense to me, that we're talking more of delayed pleural resorption. I would not have thought it to be RDS.
Okay, thank you.
That's absolutely fantastic. Thank you, everyone, for the images that you've shared today. I am going to hand over the floor to Nadya to share her presentation. I would humbly request that you all remain muted during this process, please. Thank you so much.
Could you give me 1 second, please?
No problems, Nadya.
Thank you all for your patience. Sorry about that. One of my daughters who had needed me to do something for her as an emergency. All good now. Alok, please let me know when we take a break. I know I have a tendency to speak for a long time.
No, absolutely. What we'll do is probably in about half an hour, but half an hour stage is yours. Yeah, go for it.
Great. Thank you. So we all know that the newborn baby is someone we scan very easily as compared to older children, and they're small. Although they can be vigorous, they are usually easier to scan than older patients, especially because in the beginning, at least, they have few comorbidities. And here is where it becomes interesting. Our babies have very specific diseases. And it's very interesting to see how lung ultrasound can give us an insight on what's going on, and helping us to learn more about disease processes, or at least giving us an insight to what this may be experienced as a problem. And of course, there is always the risk and our increased concern related to potential long-term risk related to radiation. I know that Alok has talked about the international guidelines we have today for critically ill neonates and children, the ESMIC guidelines. And the chapter for lung ultrasound has a number of indications. And for the newborn, this is something that we can use as a framework. It's the first step, at least, in some kind of governance. Today, lung ultrasound in newborn can be used to diagnose pneumothorax, as we saw today, diagnose the pleural effusion, and then for specific neonatal diseases such as RDS, which we're going to talk about today, TTN and meconium aspiration, and then for other kinds of lung diseases. So as you know, all the ultrasound signs are found in the newborn, but what's very particular in the beginning is the fact that the baby has a fluid-rich lung at birth. The baby will be transitioning from a fluid-filled environment to an air-filled environment. And this is the time in life where we will come in, usually, and we will be asking ourselves some questions if the baby is presenting with distress. The question could be, is it RDS? One of the questions, like we saw Anna scans today. Is it TTN? We've also seen a case about that. Or does this baby have pneumothorax? There are multiple questions also related to how we should manage this patient. Should this baby be on CPAP? Should I admit this baby to the NICU? Should I give surfactant? These are some of the few questions we're faced with every day. So I've been lucky to be able to have borrowed a few slides from Francesco Raimondi with his permission. Lung clearances, birth, and transition is really something that is fantastic. The baby will transition from fluid-filled environment and very, very quickly go on to establish functional lung residual capacity, and then, of course, hemodynamically shift from a peak circulation to transitional circulation. And we know that this is really a quite complex situation. If this is labor, if the baby is stressed, there are already mechanisms that have been put into place to reduce the production and start the reabsorption of the water in the lungs. But sometimes we know we're faced with babies that do not have time to prepare, especially, for example, when they're born after elective C-section. We know that after birth, there is a persistence of high pulmonary interstitial pressure. And I wanted to show you these because they're very interesting. These are from a rabbit model in Stuart Hooper's lab in Melbourne. And it's from preterm rabbits. And you can see these are babies that are breathing, rabbit babies. The other breathing without supplementary CPAP. And although they're breathing, you can see there's no change in lung aeration. Whilst, so we just keep on ventilating that space. Whilst if you do apply CPAP, which what our European recommendations tell us we need to do for preterm infants, you can see that slowly we have the establishment of the functional residual capacity. These lungs are getting more and more aerated with every subsequent breath. And this has also been shown. So you do with a PEP, which is what we're using, right, to PEEP around 5-6 centimeters, quite quickly establish functional residual capacity. And this is very important to lung aeration. This is very important to how we will be managing these patients. We know that there are a number of factors that do influence neonatal transition: a pregnancy, infection, and of course maternal factors. And then we know at birth there's a number of things that will influence related to also our management. I mean, the baby itself, gestational age, the surfactant pool, hemodynamic changes, and so forth. But where we come in is how we manage these babies, how we apply the pressures, how we manage the baby as an individual. And then finally, the question we'll ask, how does this really play out in the long term? So, you know what the neonatal normal lung looks like. This is a scan from Catarossi. We agree that in a normal preterm lung, as we have seen today from our colleagues, we have lung sliding, we have a nice well-aerated lung with A lines, and this can be seen whether we're doing a vertical scan or whether we're doing a transcostal horizontal scan. Again, in order to see lung sliding like this, we need to know our machine settings. In the transitional period, the lung will look a little bit different in the beginning, although the baby may be doing well. And that is, of course, completely normal because of the fact that this airway clearance is starting and it may take some time. We've learned a lot about how long it does take. First of all, we've learned that we can follow it up using serial scans before the baby takes its first breath. Well, the lung looks completely consolidated. It looks like it does in fetal ultrasound. There is no air, so we can scan the lung. And then the baby takes its first breath. And we see what we here is called type 1, so completely white lung. A whiteout appearance, and this is from the number of B lines, and quite quickly we'll have the establishment of a clear, sharp pleural line and the beginning of partial fluid clearance. And typically, in babies that do well, we have complete airway clearance that is achieved within 4 hours of life. And it has been shown to also be associated with a decrease in static lung compliance over the first 24 hours. So a decrease in number of B lines and an increase in static lung compliance. And I'm showing this pattern. This is what we're seeing. We're going from a white lung appearance. This is the broad linear probe, mixed appearance, and a normal looking appearance. So what about RDS? What would you expect to see in RDS? And again, this is one of the first papers that came out on neonatal lung ultrasound. This and the other one on CTN are really the two papers that started it all, in my opinion. The reason why we're here today really discussing about neonatal lung ultrasound is Luigi Catarossi and Roberto Copozzi, who published this paper showing that it's a question of pattern recognition. A normal lung is a black lung. That is a lung that is well aerated. An extremely sick lung is a white lung because of the B lines. It gives this white appearance. And in between, we have this mixed type, the black and white appearance. And they showed that for RDS, this is what you would see. And when you think about it, it really makes sense. What is RDS? Well, severe RDS is when we have surfactant pool that is so low that it leads to alveolar collapse. And what does alveolar collapse lead to? Well, it leads to, of course, decreased lung aeration and collapse that is more or less homogeneous all over the lung. So that makes sense, really. And when we're looking at the screen, this is exactly what we will be seeing. We're seeing the reflection of decreased surfactants, which is then showed in a uniform way all over the lungs, different lung fields. The pleural line will be thickened, like here. Difficult, I mean, we can distinguish it, but it is not sharp, it is not thin, as I know you have discussed earlier with Alok. And then we have this completely white out appearance in all lung fields, so we have no sparing. If we look at this, this is the vertical scan. We have 4 intercostal spaces. The pleural line is irregular, and it is filled with microconsolidations, what is also referred to as subpleural consolidation. So I'm a friend of Daniel Lichtenstein, and I try really to follow the way he wants us to describe things. Otherwise, I mean, I still want him to be my friend. He told me once that all consolidations are subpleural, so the use of the term subpleural doesn't make any sense. But many and most, I think, neonatal publications use that term. So these microconsolidations show that there is defects in aeration. In addition, we have so many B lines, as you can see, that it gives this whiteout appearance, and lung sliding is conserved. I just want to alert you to that there are some papers out there especially one paper using a neonatal algorithm that has got it wrong, where they have put in their algorithm that there is no lung sliding. In RDS, there is always lung sliding. In simple RDS, there is always lung sliding. If you have complicated RDS with pneumothorax, then you would use your lung sliding. So be careful with some of the papers out there. They may give wrong information. So we have preserved lung sliding. We have a thick, irregular pleural line, irregular because we have these microconsolidations, and we have no spared areas, meaning that all the lung fields look the same, which makes sense, right? You wouldn't have surfactant deficiency in one part. We could also, this is another machine, another scan, and I think the scan could be a bit better. Like during the discussion, we said we have to see how you orient your probe. I think we could have turned that around to make the view a bit sharper around the pleural line. But nevertheless, we can see that it is really not regular and it's really thickened, although, and we can also see that it's probably as tiny like defects or tiny microconsolidations, but there is lung sliding and it is completely white. Let me see if I can. And this is a picture where if you want to critique the scan, we could really have cut the depth. We have four intercostal spaces. We have a thick, thickened and irregular pleural line with lung sliding. And there are no spared areas. By spared areas, I mean no areas with A lines. The lung is not well aerated. There's a complete loss of aeration. And sometimes we might even have something that looks like this. So this is on the left side. So please forgive me for the quality of the scan. We've got the cart over here. You can see that you have multiple tiny microconsolidations, but over the area, you can see that it's taking up a larger area. So this is typical for severe RDS. Why am I saying severe RDS? Well, because I think that in preterm infants, especially very preterm infants, there is always some degree of RDS. But the ones we're very interested in, especially are the ones who will go on to need surfactants. So I call them severe RDS. And these are the ones that have been studied. And another thing is, what we do know about RDS and lung ultrasound is in care settings where these babies are treated with CPAP. We don't know much about babies in settings where these babies are not put on CPAP, as per the European recommendations. So this is an area where we don't have much information. What we do know is that when babies are treated as per current recommendations with CPAP from starting the delivery suite, if they have or don't have, sorry, I see there is a question here. Can these microconsolidations be described as static air bronchograms, or is that different? That is different. That is different. We talk about air bronchograms in larger consolidations, and I'm sure we'll discuss that in another meeting. Microconsolidations are just tiny consolidations. If we go back to, if I manage to go backwards, here we go. One more. This is a microconsolidation. So they're tiny defects. They're tiny consolidations. And bronchograms is what you typically see within a large consolidation. And by large, I mean above 0.5 to 1 centimeters. So you do not have that kind of terminology really in microconsolidations. Although we could say that here we have so many microconsolidations that it could give an aspect of tiny air bronchograms. Am I able to move on? Here we go. You could also have more severe RDS, like this one. By more severe, I mean that the aeration is more pronounced. You can see here that, going back to this question of microconsolidations, but the airway collapse here is so important that we've lost the lung sliding here, but that's because the whole lung has kind of collapsed. It's a huge consolidation, and these white spots inside, these are static bronchograms. This is a baby that we feel might benefit from surfactants and probably much more. Going back to what I said, the data we have today, on lung ultrasound and RDS is on babies that have been treated on CPAP. And we don't know anything about what it would look like and how it would be interesting in babies with RDS, severe RDS that are not on CPAP. Excuse me just for a second. My apologies, I have this horribly irritating cough and I hope not to irritate you all by the end of the day. So how does that compare to transient tachypnea of the newborn? You have shown today examples of that. But again, what's very interesting is the way that lung ultrasound will show the physiology on the ongoing disease process. Again, we have a question. Should we call consolidation atelectasis in the previous slide? I have no idea. That's a very good question. In the newborn, it is very difficult to distinguish between consolidation and atelectasis. I would probably call it atelectasis because we know it's airway collapse. But on the other hand, there are no formal studies, and really, as compared to the adults, we really have difficulties distinguishing between both when it comes to the, let's say, microscopic aspect. This, if we go over this to check whether this is consolidation or atelectasis, we don't have the shred sign, meaning that it's not this irregular consolidation we usually see. We know it's probably related to airway obstruction because we know the disease process. There are no dynamic air bronchograms, meaning that these white spots are not moving inwards or outwards. So I think this is probably atelectasis. But could I be formal about it? No, I think this is atelectasis. But for all practical purposes, really, I don't think it makes that much of a difference if we call it consolidation or atelectasis when we're using it as an addition to our clinical examination, the clinical history and monitoring tools. But it is a tricky question. For me, this is atelectasis, but am I sure? Should it technically be called that? No, I'm not sure. So going back to TTN. TTN is delayed fluid resorption. The transitional period when it comes to fluid resorption doesn't really go as it should. Maybe needs more time, like the example we saw. And what we're seeing really on the screen is exactly what's going on. It makes sense. We actually are seeing signs of the underlying physiopathology or pathophysiology on what the image is on the screen, which is that in delayed fluid resorption, what we're expecting to see is that the lower areas are fluid filled. By fluid filled, I mean that there is an interstitial syndrome. We've got multiple B lines, and we have preserved lung sliding, whilst the apexes are supposed to be better aerated, and this is what we see. And what we're also calling a sign that could distinguish RDS from TTN is the fact that we have these areas with A lines, what we call spared areas. It means that the lung does not look the same everywhere, and that is something you would expect, right? The fluid resorption is ongoing, so you will see areas, like also we saw in the previous examples by our colleagues, you've got multiple B lines, and then as you move upwards, you have clearing, like in here, you have a well-established, sharp, well-defined pleural line with lung sliding, and you could call this a double lung point. It's a tricky term, but double lung points basically means that you have two patterns on the same slide, and both of them are sliding. As compared to the long point, right? We have two patterns, but one of them is not sliding. You can also see it when you use the transcostal horizontal scan. Again, this is a fairly well aerated lung. There is lung sliding, and then we have this area where you have the multiple B lines, and the other area where the lung is normal, almost normal. And this is really the main, let's say, the difference between TTN and RDS is the fact that you've got areas with A lines, areas where the lung looks almost normal, but at least is sufficiently well aerated to have A lines. The pleural line is thin, well defined in the areas where you don't have the B lines. Of course, when you have the B lines, the pleural line cannot be regular or at least very thin because the B lines arise from the pleural line. But what we do know about TTN is that the pleural line is normal, whilst what we do know about the RDS is that the pleural line is abnormal. It is thickened with all these microconsolidations / subpleural consolidations. And there are no spared areas. And it has been shown that you don't need much experience to be able to distinguish between both of them, as in this study from the team from Udine. Basically, they grouped scanners into beginners, intermediates, and experts. And the question is whether we can distinguish patterns. This pattern recognition, going back to the black, mixed, and white types, there's a very good concordance regardless of the experience you have when it comes to distinguishing between those. So it's a question of seeing on the screen what's ongoing in the lung. And when you know the patient and when you know the clinical context, it's of a big help. But usually these are two of our main questions. Now, I don't know if I saw that you've already covered pneumothorax, but I wanted to tell you that it has been confirmed for the newborn using these signs. And very quickly then, again, going back to this lung point we discussed earlier on, show you that when we're seeing these two patterns in the same screen, this is the lung point. We've got on one side the absence of lung sliding, which when we have the correct settings is much easier to distinguish. The presence versus the absence is much easier to spot. And when we place the probe, we place it like Sujit did over the area that is not sliding, but it is of benefit really to see the difference, place it over the lung point also, which then will give you a change. So you've got sliding, not sliding, sliding, not sliding, and that will confirm that it is the lung point. And the further lateral it is, this lung point, which is the point of separation of the pleura, the larger your pneumothorax is. And quickly, because I know you know this, you can see that it's quite easy to appreciate whether it is a transcostal, so horizontal scan like here, or whether it's a vertical scan. And regardless of your mode of ventilation, as you can see here, this is a baby on high frequency ventilation, and it's very easy to distinguish the fact that here, this is, as you can see, complicated RDS. The lung is completely white, the pleural line is irregular, there are no spared areas, and then you have this area with pneumothorax. And it has been shown to be of excellent sensitivity and specificity in the newborn, and the time to diagnosis is shorter than for chest x-rays for those who are using those. I will also cover quickly meconium aspiration. And the reason I'm doing this, although I know you have talks on that, is because, again, I feel it's interesting to look at lung ultrasound as an expression of the underlying disease process. So what happens in meconium aspiration? Well, what happens is you've got the meconium, and meconium is thick, meaning meconium plugs the airways. So that means you will have airway collapse with atelectasis, like we see in panel C. We've got consolidation, like in panel A and B. We have effusion, and then there is surfactant inactivation and inflammation that comes on, So you can see here we've got an irregular pleural line with multiple B lines, and it's very dynamic. So lung ultrasound gives a 3D vision to what you would not, what you would see as a 2D image, like here in this chest X-ray. So you can make the diagnosis in chest X-ray. Almost always. I'm saying almost always because I have a clinical case to share with you after our break. But what we're seeing really is the expression of the underlying disease process. And where lung ultrasound is extremely useful, I feel, in meconium aspiration, as with other disease processes, is that you can follow your patient up serially, like Sujit showed us with the pneumothorax, right? And also Anna, who showed us with her RDS patients. The thing is, you will see a patient like this. You will manage this patient. You will change ventilation strategies according to your local protocol. You may or may not do surfactant, lavage, surfactants. I don't know. However, you treat your patient and then you can follow this patient up. These meconium plugs and this meconium will move, and it will show you a changing picture. We know that it's a very heterogeneous lung. We know that we are at risk at having overextended areas and complications like pneumothorax. And other areas that will continue to be underventilated. You might want to position your patient. You might want to change your airway management, not airway, your lung ventilation strategies. And you might follow up to see how this lung is re-aerating without causing too much damage. So for me, this is very interesting. Although, of course, in most cases, you can make the diagnosis. It's more a question of how you manage your patients with meconium aspiration as, for example, making diagnosis on its own. Having said that, I think we have time to show you this clinical case before we break. So this is a term infant who was born in a clinic. I work in a tertiary unit. She was referred to us. There was no history for infection. The pregnancy went well. There was nothing really. She had good birth weight and everything. And then within the first hour, she developed severe and quickly progressive respiratory distress that led to the neonatologist on site to intubate. So there was a history for tainted amniotic fluid, but there was nothing on intubation. And very quickly, she became severely hypoxic and the transport team was called in. This is her chest X-ray. So by now, you must have understood that I'm not very good in chest X-rays. I can see that it's not 100% normal. I guess there's some tiny stuff over here. But in no way does this, for me, explain her severe respiratory distress. So the transport team came in, and we quickly assume that there's probably difficulties in transitioning, especially regarding hemodynamics, that it might be PPHN. So she was put on high frequency ventilation and inhaled nitric oxide, but she was very hypoxic. They managed to get her sats up to 90% on 100% FiO2, and she was paralyzed for transport. And by that time, we suspected congenital heart disease, and we called cardiology, and she came to our unit for stabilization. So I was a consultant on call, and the first thing I did, usually I start up with the lungs, but then I started up with the heart. The heart looked good. Of course, I was waiting cardiology. I'm not a cardiologist, but I mean, the heart looked really structurally well. There was no transposition of the great arteries, no coarctation. I even saw 4 nice pulmonary veins. I was very proud of myself. And I thought, well, this heart looks good. And then I moved to the lung. And this is where I started to relax, because this is the anterior scan. So they're maybe not as nicely labeled as yours, but I think you can see that the pleural line here is very regular. We have consolidation, and the lung looks white. When we move laterally, then we have larger consolidations that appear. And this is on both sides. And when we arrive to the lateral sides, on both sides, right and left, we have complete atelectasis with complete airway collapse, and also effusion in the posterior lateral areas. And this is what it looks like on a scan. So this is the right lateral scan. We have 3 intercostal spaces. There is or there is not lung sliding. I'm not sure about that, but what we have is completely non-aerated lung. We've got fluid all around, right? So this is a completely non-aerated lung. By this time, this patient was on a high frequency oscillation, 20 of mean airway pressure, sats of 91% to 100% oxygen. But then I knew what I needed to do, right? It's very easy when you see a scan like this and you relax completely and you smile because you know what you should do. I just increased mean airway pressure. And when I did this, when I managed to go above the opening point, well, suddenly the patient started to saturate. And we could, wean her off oxygen, was on 26. The lung is sick, but you can see the A lines, you can see the B lines. And this patient was extubated within 36 hours, and she was room and she did well. So our conclusion was that this was most probably a case of aspiration leading to airway collapse. So she had non-aerated lung. And just to show you a chest X-ray. I think maybe we could break now. Alok, what do you think?
I agree completely. Yep. And a really good example of how we can use lung ultrasound to actually guide a clinical diagnosis with, not much in terms of on the X-rays. It's amazing. Yeah.
Did we break?
So folks, we have a little bit of a break before Nadya moves on to the next presentation. And I was going to welcome any questions that colleagues have. So who would like to go first? So one of the questions that I kind of have at this point, Nadya, is for RDS, we obviously have a kind of a clinical progress that the baby shows. And in particular for babies who are not intubated and ventilated, we kind of, in that situation, use lung ultrasound. And I'm just curious, I mean, for your practice, normally a lot of units would get an initial kind of X-ray lines, look at the lungs and look at the clinical status of the baby and help us kind of delineate when we think a baby is heading towards surfactant. I was keen to know what and how you use lung ultrasound, at what age in particular you're doing your first scans, and what your clinical practice is.
Yeah, look, if you would allow me, I'm going to talk a little bit about that later.
No problem.
So we don't do any chest X-rays.
Yeah.
However, it is part of our, let's say, a bundle of care for the preterm infants. They are on CPAP, the delivery suites. And then when they come to our units, they get their lines in, and we start parenteral nutrition, caffeine. And within the first 45 minutes, we then do the lung ultrasound scan, because that leaves them some time to recruit their lungs on CPAPs, or our babies are on CPAP.
So I can see that we have a question with a raised hand. Yep, go for it, Sujit.
Nadya, thank you so much. My question was in terms of your day-to-day management of extremely preterm infants with PDA. Do you incorporate your lung ultrasound in your decision-making for management of the duct?
Thank you very much for that question. It's a very important one, but also a very tricky one. So we all know that we don't know what we really should do with the PDA. This is one of the ongoing controversies. So in our units, we do a scan. So that means a lung, brain, and echo in our babies at 3 days of age to evaluate whether we have a hemodynamically significant PDA or not. And this is where it becomes tricky, because if the baby has severe RDS and has received surfactant, the lungs then might still not have cleared, and this is often the case that you have light lungs. So using them PDA, using the lungs then for PDA assessments is a bit tricky, because you can't really say if this lung edema, I call that edema, is due to RDS or if it's due to pulmonary overflow. That's a bit difficult. However, because we've already scanned the baby, if this baby has a worsening picture, the lung wasn't white at birth, or the baby didn't receive surfactant, and then this is a large duct, and the lungs clearly are becoming more and more interstitial, then that could be an argument. However, in older babies, the ones, for example, who have either failed their courses for treatment for PDA, you didn't have significant PDA, so were not treated, and then you see that, and then we take into account the lung picture, because by then these babies should have cleared their lungs at some point. But it is a tricky question. I know there is 1 or 2 papers out there, but there's always the limitation of the fact that you're dealing with babies who have, I mean, lungs that are very interstitial. I think it would be very, very interesting to explore that multi-centerly, or collaborating at least, to find out how we can use this. I think it's very promising, but I'm not quite sure what the best way to do it is yet. So thank you for that question, Sajid.
Thank you.
We've got another question from Subhash. He's basically asking about subpleural consolidations, and the kind of physiology of the lung ultrasound is the message I'm getting in terms of why we get subpleural consolidations in RDS. Is it kind of because of atelectasis, or do we think that it's because we've got surfactant deficiency and blockage of the bronchi?
I hope I did understand the question. I think that subpleural consolidation, you didn't hear that word from me. Don't tell Daniel Liechtenstein. They're micro atelectasis. They're micro, I mean, it's airway collapse, but it's not so major that the whole, I mean, the whole say lobe is collapsed. So that is because of RDS and increased surface tension in the alveoli.
That's really helpful. Mayank, do you want to ask your question to Nadya?
Yep. So I was a little confused when I saw some of the scans, which was, am I audible?
You're audible.
Okay. So there were few scans which showed the lung point. However, the non-sliding pleura, the part where the non-sliding pleura was, it was in the lower part of the scan. So I was expecting to be more cranially or in the upper part, because I believe that the air would be, if the baby is supine, the air would be first located, or the would be in the upper part rather than in the lower part.
Sorry, are you asking about the lung points within the lower upper part? It's, for me, both in the upper and lower part. It's about the lateral or the medial part. And the scans we saw, we had 2 scans showing absent lung sliding, and I agree. We had the absent lung sliding was where it was in the different, it was in the upper part for sure. I agree with you, but I think it's more a question of when you move that laterally that you will then find out where it is. So maybe Sujit could tell us a bit more about how he did the scans, but it shouldn't be upper or lower unless you have a very like you have some emphysema, or you have really just a small bubble of air, which was what we did see in the scan with the chest tube that was there. So I'm not really sure I did answer your question, but then I'm not really sure I did understand the question. So please let me know.
Okay, so your presentation also had that severe RDS with pneumothorax. So in that scan as well, I saw that the wet lung part was in the upper part, and the non-sliding pleura with A lines was in the lower part of the same scan. So I couldn't understand how this distribution was happening, because I expected the non-sliding pleura and the A line would be in the upper part of the scan, and the normal lungs or the wet lung would be in the lower part. So there was one slide with a scan of severe RDS with which was complicated by pneumothorax. Yeah, right, this one.
So if this is the right lung and you're moving this laterally, this is what you would see.
Okay, so you are moving horizontally in the intercostal space from medially to laterally. Okay, I got it. Thank you.
Okay. So you've scanned and then you're moving laterally. So this is the right side of the patient. And this is the left side of the patient, right? And this is the right lung. So you can see that is the left part, i.e. the medial part of this lung that is not sliding. And when you move it laterally, this is where you find the sliding. Does that make sense?
Yes, it does. It does.
Yeah,
But
you're moving the probe horizontally. You're not moving the probe
the position
vertically.
of the ribs.
Yeah.
I can see several ribs over. So is it placed vertically or horizontally?
This is the vertical scan, and you have 1, 2, 3 ribs. So you've got 1, 2, 3 intercostal spaces.
Okay.
Does that make sense?
Yeah, that's clear.
You don't have any rib shadowing because the ribs are probably not ossified yet. But you have a vertical scan. So you have the bad sign, and then you're moving your probe in a vertical position. You're moving it horizontally, laterally. And you're moving it so you find this place here.
Okay.
But you're not moving it upwards or downwards.
Okay.
Which is, yeah, this is the same thing you would do in a horizontal scan. So you don't have the bad sign. And again, you'd move it also horizontally. You have a horizontal view until you find this. And the same in this one here. So you've moved it. There's no sliding, and then you move it horizontally till you find this area of separation of the two pleura. So this is the right and this is the left. So this is medial in this patient and this is lateral. These are both right lungs.
That's beautiful. What we're going to do is, because we've got about 20 minutes of presentation time, I'm going to let Nadya carry on.
So we're moving on with RDS. And really the use of lung ultrasound as a functional tool. And because lung ultrasound is so good in evaluating the loss of lung aeration, we're going to see how we're using it in the scoring system that I see you already know. This is for me really the summary of what lung ultrasound is all about. It's really the images we see on the screen, whether they be artifacts or real images that are in relationship of the ratio of air and fluid in the lung. So a normal lung is around 98% air, right? So we've got the A lines, and then we have the B lines appearing when we have increased edema and fluid. And that brings us all the way down from a few B lines to a completely white lung appearance, like in severe RDS. And all the way at the bottom, we have non-aerated lung, like in atelectasis and consolidation. So we're really concentrating on mix of A lines and B lines and consolidations. And what we do know is with increasing lung edema, so basically increasing fluid components, we'll have an increasing number of B lines. And there are multiple lung ultrasound aeration scores that are available today. They're being used to guide respiratory management, evaluate for extravascular lung water and response to treatment, And in the newborn, they're being used especially for surfactant administration and for monitoring of progression towards chronic lung disease. So this is the first paper really that came out to show that we can use lung ultrasound to predict respiratory outcome. The paper by Francesco Raimondi used a simple scoring system, 1, 2, 3. All the babies in the group 1 went on to need admission to the NICU for respiratory distress. None in the group C did, so group 3, and a few in the middle. And he goes on to show, and I will show you, that the group 1, they all failed non-invasive ventilation. And the key message here was that lung fluid content can be assessed non-invasively at birth, and that, as I did show you, there is this aeration that appears, but when it doesn't appear, the fact that you can use lung ultrasound early on as a reliable identification of the babies who will need respiratory support and admission to the NICU is very interesting. So the question is, can we take it a step further, and can we make this more into something quantitative or semi-quantitative? And this is where breadth scores came in. Really, as you know, it's a very simple score. You divide each lung into 3 areas, and then you see the artifacts you see on the screen. If you have less than 3 B-lines per intercostal space, but again, you have to have a global overview. We don't really care about one single intercostal space. You have to have a global overview. If you have a well-aerated lung with less than 3 B-lines per intercostal space, you will score to 0. If you do have B-lines, many B-lines, more than 3 or more per intercostal space, but you still can see your A-lines, then it's a 1. If it's a completely white lung where you don't have any A-lines or hardly any, it's a 2. And if you have a consolidation above 0.5 to 1 centimeter, it's a 3. And basically, this is it. We have less than 3, 3 or more, but we can still see the A-lines, completely white or consolidation. And we know that it correlates significantly with oxygenation indexes, and that's interesting because in Europe, at least, the European recommendations recommend surfactant administration for an FI2 threshold when a baby presents with respiratory distress. And as you can see, this worked really well for babies below 34 weeks, not as good for babies over 34 weeks. But then when you look at the babies below 28 and 32 weeks, which are really the area of the babies we need to be concentrating on, you can see it works even better. But going back to Francesco Raimondi and his pattern recognition, well, he showed that this is also a way you can predict failure of non-invasive ventilation. When he shows this picture of these twins, I think they're 30, 31 weeks old. They both have respiratory distress. One of them goes on to need surfactants and one of them does not. And I told you I'm not that good with chest x-rays. For me, both don't look okay. But it helps me a lot to see these scans. This baby over here went on to need the surfactant administration and this baby did not. And he validated really, or let's say confirmed the findings that Bracknell had shown. So our challenge is this, right? We know that in the smallest babies, we need to selectively give surfactants, and we need to give it early on, within 2 to 3 hours, to reduce mortality and BPD. However, we don't have any easy bedside tools to estimate lung volume. So how can we actually do that? Our European recommendations tells us to give surfactants based on FI2 levels, but that often happens later than 2-3 hours of life. So this is where lung ultrasound comes in at a very interesting tool. This was for babies below 34 and above 34, but when you look at the extremely preterm infants, the prediction value is much more interesting. What the study shows is that babies below 32 weeks of age, when you do the lung ultrasound scan, as I described, that is to say within the first hour of life, in babies with CPAP, what you can see is that the area on the curve for first surfactant treatment is really excellent. So before this baby starts even to have increasing oxygen requirements, baby on CPAP, you can predict which baby will fail non-invasive ventilation as per European guidelines. And we changed our clinical protocol to Esther, which I will show you after we came to this conclusion, meaning that this is our golden hour protocol. The babies will come in. They come in from the delivery suite on CPAP. We check that they are receiving their CPAP pressures. And then we put in the lines, we start parental nutrition, and we then do the lung ultrasound scan within 45 minutes. And then we leave the baby alone if the scan shows that the lung ultrasound score is below 8. Or if the baby has a score above 8, then we'll prepare for surfactant administration. So in France, echography is used for ultrasound. So Esther is echography guided surfactant therapy. And we're using Brad's score. And then what we're doing is we're scanning the whole lung, but we're only scoring the anterior and lateral chest regions. The score of 0 is this up here. You can see there are 3 intercostal spaces. There's maybe 1 B line, maybe not, but this is a 0. This is a mixed picture where we have multiple B lines, but we still have multiple A lines. So this is a 1, as compared to a score of 2 when we have no A lines at all, and consolidation, which is a 3. So for example, to show you a baby that has come into a unit which is very sick, this baby is already in high frequency ventilation, so it's not doing that well, but still is to show you how quickly it could take us to scan a baby that is critically ill without disturbing it too much. So this is right anterior superior. You can see that the pleural line is irregular, but there is lung sliding. And we scan all the way down to the diaphragm. We have multiple intercostal spaces per scan. And then we go laterally all the way down to the diaphragm. There is preserved lung sliding. The pleural line is very irregular. Multiple microconsolidations, pleural consolidations. And then we will scan posteriorly. So we're not moving the baby in any way, which is why here, because we're using a hockey stick probe, it's horizontal, so transcostal stand, because otherwise the hockey stick will not slip backwards. There you can see there is a larger areas of microconsolidation, and there's even pleural effusion. So we will not score this area, but we will definitely use it for diagnosis. And then we move on to the left side, always tricky with the heart. But we can see that it's uniform. The lung is really white everywhere, right? It's a white lung appearance. Consolidation. There's one over here that could be maybe 0.2 millimeters, 0.2 centimeters, sorry. And then posteriorly, no, this is laterally, sorry. I had a nice kidney there also. And then we'll move on to the back again without disturbing the baby. And you can see there's a larger area of consolidation here, right? The baby lung is not sliding that well there. A little bit of effusion, but we will not be scoring this area. So you can see this is a very sick, non-aerated lung, and we can see this really early on. So this baby is a candidate for surfactant. Of course, there's no surprise in this case because the baby is not clinically well. But if this baby had been on 21% room air, we would still have given it surfactant. So this is a score of 12. It's not a score of 18 because the consolidations are then posteriorly. So we changed our clinical protocol to Esther, sorry, meaning that we give surfactant either based on FI2 thresholds and or lung ultrasound scores above 8, whichever comes first. And we wanted to be sure that it actually improved our quality of care because we were getting babies in and we were doing fairly well when it came to giving surfactant within 3 hours of life, but we could definitely do better. And then we changed our protocol, and as you can see, become much more uniform with a few outliers. We significantly increased the proportion of the babies who did receive surfactant within the 3 hours of life, and we decreased the FI2, maximum FI2 levels. We also, in the secondary outcomes, so that there was a decrease in the duration of ventilation and an increase in the number of ventilator-free days. And it didn't come at the cost of increasing surfactants. We were still giving the same amount of surfactants. We were not giving less either. When it comes to surfactant-free treatment, we don't have enough data to really recommend using lung ultrasound scores for that. This is the only prospective randomized controlled trial on the use of lung ultrasound scores for surfactant administration. The ultrasound SURF trial was held in Spain, where the babies were randomized to either a control group, which received standard care, that is to say surfactant based on European recommendations, and the ultrasound group, which received surfactant as per, Esther. And as you can see, well, we're in France, so we don't call this a pie chart, we call these the camembert. You can see that the ultrasound group 100% received surfactant within 2 to 3 hours, 3 hours of life, whilst the control group only 8% did. And there was a difference in outcomes after that when it came to SAC levels, FI2 levels, after surfactant administration. We also have other studies that show the same thing, either using different scoring systems or the pattern recognition I showed you. Like this study by Raimondi, which is an Italian study, that showed that lung ultrasound scores reliably predict the need for surfactant administration in preterm infants. As you can see, the ROC curve is really good. And what they did was they included another parameter. They included an SpO2 FiO2 factor, and they found that it actually increased the performance and the predictivity of the need for surfactants. There's been a lot of criticism on using really that criterion, but what they show is that it seems to work, at least as a clinical tool. And we have also had a number of meta-analyses. This was the first one with 4 diagnostic studies. 6, this was the second one, and you can see they all showed the same thing. And here is one that just came out right now. Came out in January. This is a multi-center, let's say, effort that has then used the available studies we have now, which are 8 studies with different lung ultrasound cutoffs. And you can see that it gives this really, really nice ROC curve. And the conclusion is that lung ultrasound is highly predictive for the need for early surfactant replacements. And that the studies they did use were, there was little bias. However, of course, there is variation in the way we're using the scores and the different scores we're using. There are 2 image classification systems that I have shown you. One of them is Brad score and some variations of that one. And the other one is the 1, 2, 3 score that's being used, for example, by Francesco Raimondi. So it's a scale system. But both of them work really well for neonatal RDS and surfactant administration. That is probably because it's a very homogeneous disease. So the profiles is a reliable, so one profile, a white lung, is a reliable marker of poor aeration and for surfactant administration. There's less evidence on that use as compared to lung ultrasound scores. And also, we have to acknowledge that including this SAT-FI2 parameter, you have better performance than the individual parameters as predictors for early surfactant requirements. So the conclusion is that there are some methodological differences that we need to address, and we need to have standardized scoring systems. Having said that, we know that scoring systems work much better than or as well as more invasive methods, like, for example, ex vivo measured lung volumes, scans, and so forth. So it's a very well-documented scan after all. I think that we conclude that today, lung ultrasound is the only available bed score today to evaluate lung aeration in preterm infants. It's highly predictive for the needs for early surfactant administration in preterm infants, at least below 32 weeks, much more complicated when we're talking about near-term infants, that we have multiple scoring systems, but they all are validated and they all work really well. But there is a need for standardization. Then the question, of course, is raised about what about the impact in limited research settings that we don't know much about. So in conclusion, this is a very interesting tool. Again, as I didn't maybe not show in this meta-analysis, we do not have enough data on what I call surfactant retreatment, which is basically a second or a third dose of surfactants. There is not enough evidence leaning towards the use of lung ultrasound alone to decide on whether or not you give a second dose of surfactants. You have to use other criteria, clinical criteria, FI2 values, and so forth. Now I have a question about what is the meaning of, no, can ester be applied on a 4 days old baby who only had 1 dose of surfactant a day? No, again, this is not something that you can use for a second dose of surfactant. You could as an additional criterion, but there are too many other things that come into account, and also there is not much data on it. So I'd like to thank you for listening and bearing with me with my horrible voice and my horrible cough. And I'd like to thank the teams I work with. And yes, I'm ready to take your questions.
Thank you very much, Dr. Nadya, for this fruitful presentation. It was very obvious and straight to the point. Just I have one question. Do you recommend any preset setting for a preterm and third baby as if of looking for frequency? I'm talking about frequency.
I would recommend having the highest frequency possible, whether it is for preterm or term infants. They're small. I mean, they're very small. Of course, the smaller the baby, the easier they are to scan. You put the probe on a 500-gram baby and you scan the whole lung in one setting. 4 kilos, like we saw, is a bit more challenging, but I would use the highest frequency possible on most of the probes. And I know you have discussed this. You have the possibility of switching. There are often a range of frequencies, so choose the highest you can. When it comes to the presets you use will vary from one machine to the other. The most important thing for me is that you're able to see lung sliding. For me, this is an essential part of the examination. Depending now on how you've also set your settings, you will have your number of B lines that might change a little bit. Actually, the number of B lines changes, as you had discussed before, with respiration of how you're holding your probe. So this is a global, my message is this is a global overview. You cannot get stuck on assessing one little quadrant of the baby's lung unless you're checking for something else, like consolidation, for example. But presets are the ones that allow you to see lung sliding, that allow you to be able to identify your B lines, and that give you really the best image quality you can get on your machine. And sometimes you need some time to find them. So on our machine, we have lung ultrasound settings on each probe, because you can use any probe you want freely. Although I would recommend a linear, microlinear hockey stick probe with a high frequency if you have access to that. But if you don't have access to that, and I'm sure Alok has talked about that, do not feel limited by that. You have to learn to know what the machines look at on your, what the images look like on your machine. That's the most important thing. And don't limit yourself to presets. Play around, get to know your machine. So Anna was saying, I'm confused on sagittal stand. Don't we have cranial on left and caudal on right? On the screen, I mean, it's the left side of the screen is always the right side, left side of the screen. Yeah, it depends how we're switching. Of course, I'm a bit challenged when it comes left to right. But cranial is always the same as right, is always, so that would make sense, Anna, I guess. So don't we have cranial on left and caudal on right? If you've inversed the screen like radiology does, it's cranial on left, on right. Alok, could you answer that, because I'm a bit confused about the question.
Maybe I can explain better.
Yeah, Anna, please go ahead.
When you showed the scan of the pneumothorax that Mayank questioned, you said that you are coming laterally. So the lateral parts of the baby,
yeah,
you were doing a sagittal, not a longitudinal scan. I didn't understand that.
So you can do both scans. So again, just coming back to our initial lectures, what we want to do is use standardized terminology. And classically, from our perspective, you'd have a longitudinal or a transverse scan. Now, you must always remember the baby's supine and air is anterior. So as air rises up, if you're moving from the middle of the chest laterally, obviously air being anterior, you'll get air first, and then at some point you'll start seeing lung. So what Nadya is saying is that, say if you started laterally, that is in the axilla, and you were seeing lung, because the air is anterior and medial. At some point you'll encounter a lung point, and then you'll encounter air. So I wouldn't get confused with cranial or caudal, which kind of means towards the head and towards the leg, which is not relevant here.
Yes, but it was not in this scan. It was in the sagittal one, not in the longitudinal. It's another one. In this one.
Yeah.
It is not a longitudinal scan.
It is.
Yep.
It is a longitudinal.
It's a longitudinal scan. You can see multiple rib spaces.
Yes,
it's not a transverse
scan.
No, it's not.
Why do you say that it's the right and the left of the baby?
But this is always the right side of the baby, and this is always the left side of the baby. In a longitudinal, so vertical, I don't know how, which terminology.
Yes, vertical, yes.
Is it? Yeah, we're here. I'm putting my probe like this. So this is moving laterally. In this case, this is the right lung, which is why I'm moving towards the right of the patient. This is right, this is left.
Okay.
I'm not
right
scanning
lung.
up and down right now. This is the right lung. If it had been the left lung, then this part would not have been, I would have been moving this way. And then I would be moving from right to left. Now I'm moving from.
Okay, thank you.
Did I help you? And now are you even more confused now?
I understand. Thank you.
Yeah.
So
How do I stop sharing?
I wanted to ask if there are any other questions. Does anybody have any questions that are not written down?
I think there is a question here we haven't answered. Yeah, there was one question again that's like Anna's question, and then we have what did I say regarding large pneumothorax? The signs in large pneumothorax are the same as small pneumothorax. It's just a question of where you find the position of your lung point, meaning that the further from the middle you are, so you're moving your probe laterally, the further away you are, the larger your pneumothorax is. But the signs are exactly the same, because what you're seeing is really the limitation of ultrasound. Ultrasound beams can't go through air. So if you have air between your two pleural leaflets, you can't see anything. So basically, it would be the same, whatever the volume. The thing is, where you're putting your probe, the ultrasound beams will stop at your parietal pleura. They can't go any further because there's air after that, right? So they just bounce back. That means you will only see basically the pleural line, which is the last thing you see, and then repetitions of that, which is the A lines, because there's air, because they keep bouncing back. You cannot see anything else. So the thing is, it's just the place where you find the normal lung, or at least the sliding lung, that will give you an indication on the size, but the signs are exactly the same.
So we've got Kirti asking 2 short questions. Go for it, Kirti. Yeah.
Because I know that in your unit, you don't generally do x-rays. So for that ET2 position, do you change your probe to sector probe and then measure from aortic arch, or do you use the linear probe itself?
That's a very good question. So For some reason, our settings on our machine for the linear probe are difficult to really see the ET tube well. So I use the cardiac probe. But I know, for example, Luca, what's his family name? Bonvidis, who is working in Italy, is it in Padua? He's really incredible when it comes to ET tube positioning, and he uses a linear probe, and he tells me it's a question of settings. The juniors there, I mean, the trainees, they do this in a few seconds. So I use a cardiac probe because with my settings, I still haven't managed to find the ideal setting, although sometimes I manage with linear probe. So yes, I will change the view, I will find the aortic arch, and then I will identify the trachea, and then, yeah, at least the ET tube, yeah.
Thank you. And for lung recruitment, then how do you decide based on lung ultrasound? Do you use that pattern of S pattern to be where it reaches the opening pressure? Is that how you do it?
Well, I think it's a multiple ways of doing it. It's pattern recognition. The fact if you have like the meconium baby, if you got a consolidation, and this is atelectasis non-aerated lung, and it explained the clinical picture basically, which is why we went in to see how when we could open the lung, it just looked like non-aerated lung. Once we reached the opening pressure, we saw once that the baby changed clinically also, and then we moved down the pressure to the minimum. In other babies, like for example, with more heterogeneous lung, or babies where you want to go slowly, it's not just a question of an atelectasis you want to open up. We often use the lung ultrasound scoring system, and then we will recruit according to that, or position the baby prone. A typical patient population would be babies with developing or evolving BPD. They're horrible, right? They're horrible when it comes to difficulties in breathing, increased work of breathing, stuff like that. I mean, as per human beings, they're not horrible at all. They're lovely. But when it comes to the lungs, it's a bit difficult. So we would use lung ultrasound scores and lung ultrasound patterns to adjust pressure settings. We're probably a bit too aggressive on non-invasive ventilation. We hardly have any ventilated babies. So we'll move the pressure settings, or we'll position the baby differently. So prone position, for example, they're using prone, or maybe on the side if there's a large atelectasis and so forth. So it's a question of identifying larger areas of the recruitment, atelectasis consolidation, and using the score when it comes to fine tuning. Did I answer your question, Kirti? Yeah.
Thank you.
Yeah, thanks.
Yeah. One last question before we let Nadya go, and I just want to take this opportunity first to thank Nadya, giving us her time on a weekend. God bless you. My next question is for the ESTER study. I mean, we clearly have evidence that we've improved and helped with early administration of surfactant treatment of RDS. Have we looked at long-term clinical outcomes just for the babies? And I think that would be very difficult, because you'd have to look at the cohort of babies after the intervention versus the cohort of babies before, and you wouldn't be able to control for a lot of things before and after. So I think, that's will be very difficult. But yeah, I'll let Nadya answer that question here.
I think you have answered the question. And look, we don't really know much, do we, about what early. I mean, we have the Bowel, etc., who says that to improve long-term outcomes when it's related to mortality and BPD. What is BPD? You have to give surfactant within the first 2 or ideally 2 or 3 hours of life, right? However, we know that BPD is extremely complex. It's multifactorial, as you said, Alok. So the shifting from, let's say, standard approach to an ESTER approach, how much would that influence later outcomes? I don't know. How could we manage to test for that? I mean, we've got, like you said, so many different parameters that come in. You've got infection, you've got large PDA if you treat or you don't treat, depending on what your policy is. You've got, genetic susceptibilities.
Yeah.
So I think that the first step in this is the work that's ongoing on the trajectory of BPD, however we define BPD. Because we still don't even know what BPD is. We don't know what that is later in life. We have no idea, right?
I have a question, Nadya, and I'm desperate to ask it. So this is the slight challenge, because we've defined BPD, 28 days, the oxygen requirement. But clearly we know that the lung changes that appear much before that, you have evolving lung disease. And I think lung ultrasound and what we're seeing, when you're doing sedal scanning for these babies, is there kind of a consensus move towards trying to see if we can actually define evolving lung disease after RDS. On ultrasound.
I think we're starting to address the question by actually documenting the lung changes you can see. So clearing up after RDS, how these babies, we do know that already at 1 week or the first days of life, but let's say 1 week, that there is a clear difference in the lung ultrasound pictures in babies who go on to develop BPD as defined at 36 weeks, classically, whatever definition you use, and the ones who don't. So we know this is something that is ongoing, and at 1 and at 2 weeks, I did show the slide, but I took it off really quickly because we'll discuss that at some later point. We know that there's something going on, and now for the first time, we're actually recording that. We're recording it maybe using a score, that is fine, but we're seeing that there is something ongoing. So the first time we're actually able to address the evolving changes in the lung. So the next step would be, I think, to know more about that. And then possibly also, and I know there are some people who are itching to try and follow these babies up after discharge also. So I think the question is out there. I agree with you, Alok. It's early surfactant versus BPD or long-term outcomes in life, unknown. But the fact that for the first time we're actually able to visualize changes might be the first step in learning more. I'm hopeful.
That's fantastic. Thank you so much, Nadya. We're so grateful. I will thank everybody for attending the session today, and we look forward to the next talk. Thank you, everybody. God bless you.
Thank you, everyone. Thank you for being so interactive, and sorry about my cough. Hopefully next time you can hear me better. Okay.